Let me tell you about something I see in the emergency department that consistently catches people off guard, not because the diagnosis is rare, but because of how completely it contradicts what the patient expected to hear. Someone comes in, mid-50s, typically, referred by their GP after a blood test came back with elevated liver enzymes, ALT, AST, that nobody had been looking for. There was no specific reason to check. It came upon a panel ordered for something else entirely. The patient has no pain, no jaundice, no swelling in the abdomen, nothing that they would describe as a liver symptom. What they do have, when you sit down and take a careful history, is a constellation of things they had been attributing to entirely separate causes for several years. Persistent fatigue that sleep doesn't fully resolve, a tendency to feel uncomfortably full after moderate meals, skin that has been itching, particularly in the evenings, for reasons no cream has been able to explain, a slightly thickened waistline that hasn't responded to dieting the way it used to, occasional dull aching on the right side of the upper abdomen that they assumed was muscle or posture or a trapped nerve. None of these things individually would send a person to their GP concerned about their liver. Together, they were the liver, signalling in its indirect and easily misread way that it had been under strain for longer than anyone had realized. The liver cannot raise an alarm in the way that a diseased heart or a diseased kidney can. It has no pain receptors in its tissue. It does not produce a specific, unambiguous symptom in its early stages of dysfunction. What it produces instead is a set of systemic signals expressed through the skin, the gut, the energy systems, the hormonal environment that are easy to misattribute and easy to ignore. The liver sends signals before it fails. They do not look like liver symptoms. They look like tiredness, skin problems, digestive complaints, and stubborn weight, until someone connects them. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years working in the AANDE, I've seen liver disease at its most advanced and most irreversible. The cirrhosis complications, the acute liver failures, the patients and families confronting a diagnosis that accumulated silently for a decade before it announced itself. My goal now is to help people recognize the earlier signals, the ones that appear years before a liver function test is ever ordered, so they can act while the liver still has the extraordinary capacity for regeneration and recovery that makes early intervention so much more effective than late diagnosis. If you're watching this video, something about your energy, your digestion, or a recent blood result has probably prompted the question of whether your liver might be involved. And I want to make you a promise. I promise to keep creating the most detailed, evidence-based videos. I can ground it in clinical experience and the latest research to help you understand your body and protect your long-term health. All I ask in return is that you give this channel a chance and hit the subscribe button. If you reach the end of this video and haven't genuinely learned something new, feel free to unsubscribe, no hard feelings at all, but if you give me your time and attention, I'll give you everything I've learned from nearly a decade in emergency medicine. Please hit subscribe to help this channel reach more people like you. And let's get into the 7 signals. Before we go through the 7 signals, it is worth establishing what liver stress means biologically, because the term is used loosely, and the biology behind it explains exactly why the signals manifest the way they do. The liver is the body's primary metabolic processing center. It performs more than 500 distinct physiological functions, including detoxification of circulating compounds, synthesis of proteins, including clotting factors and albumin, production of bile for fat digestion, glucose storage and release, cholesterol metabolism, hormone processing and deactivation, and the conversion of ammonia, a toxic byproduct of protein metabolism, into urea for urinary excretion. This metabolic breadth means that when the liver is under stress, when its function is being impaired by fat accumulation, inflammation, toxin load, or oxidative damage, the consequences are not confined to one organ system. They ripple outward across every system the liver serves. The most common cause of liver stress in the developed world today is not alcohol. It is non-alcoholic fatty liver disease, NAFLD. The accumulation of fat in liver cells driven by insulin resistance, excess fructose metabolism, and the portal-free fatty acid delivery from visceral fat described in the belly fat video. NAFLD is present in approximately 1 in 3 adults in the UK, Australia, and the United States, the majority of whom are entirely unaware of it because their liver function tests are either normal or only mildly elevated at a level that does not trigger investigation. The liver's functional reserve is large enough to compensate for early fat accumulation without producing abnormal standard blood markers, which is precisely why the signals described in this video are important. They appear before the blood tests confirm the problem in a tissue that will not complain until significant damage has already occurred. NAFLD is the most common liver disease in the developed world, present in roughly 1 in 3 adults, and the majority have no idea it is there. The 7 signals below are how it makes itself known before the blood tests catch up. Just very quickly, if you're finding this useful so far, please hit subscribe. It genuinely helps these videos reach more people who need this information. Right, let's get into the signals. Let's go through each signal in turn, what it is, the specific biological mechanism connecting it to liver function, and why it is so consistently attributed to other causes. As with the metabolic and stress warning signs discussed in previous videos, no single signal here is diagnostic in isolation. It is the pattern of several occurring together, particularly in someone with the metabolic risk profile for NAFLD, insulin resistance, visceral fat, elevated triglycerides, or a diet high in refined carbohydrates and fructose that carries clinical weight. Signal 1, persistent fatigue disproportionate to physical exertion or sleep. The first and most pervasive liver stress signal is fatigue, not simple tiredness that resolves with rest, but a sustained background exhaustion that feels qualitatively different and that does not track with sleep quality or physical demand. Patients with NAFLD and early hepatic dysfunction consistently report fatigue as their most debilitating symptom, and it frequently precedes any abnormality on standard liver function tests. The mechanism is multifactorial. Fat-infiltrated hepatocytes, liver cells, have impaired mitochondrial function, reducing the efficiency of ATP production in the organ that is the metabolic center of the entire body. The systemic inflammatory cytokines produced by inflamed liver tissue, particularly TNF-alpha and interleukin-6, act on the central nervous system to produce a state of sickness behavior that manifests as fatigue, cognitive slowing, and reduced motivation. Additionally, impaired liver function compromises the conversion of thyroid hormone from its inactive T4 form to its active T3 form, which occurs primarily in the liver, meaning hepatic dysfunction can produce a functional hypothyroid state even when the thyroid gland itself is entirely healthy, with all the fatigue implications that subclinical hypothyroidism carries. Liver-related fatigue is not random. It is the combined effect of impaired cellular energy production, central inflammatory signaling, and reduced thyroid hormone activation, all operating simultaneously in an organ whose dysfunction the standard fatigue workup rarely considers. Signal 2, persistent itching, particularly in the evening or at night. The second signal is one of the most specific and least expected on this list. Generalized pruritus, itching across the skin without any visible rash or dermatological explanation that intensifies in the evening or at night and does not respond to antihistamines or topical treatments, is a recognized, though underappreciated, early indicator of hepatic dysfunction. The mechanism involves bile salt metabolism. The liver produces bile, which is stored in the gallbladder and released into the small intestine to emulsify dietary fats. When hepatic function is impaired, bile salt metabolism becomes dysregulated, and bile salts accumulate in the circulation at concentrations that irritate peripheral sensory nerve endings in the skin. This process, called cholestatic pruritus, is well established in the context of advanced liver disease and intrahepatic cholestasis, but occurs at a subclinical level in NAFLD and early hepatic inflammation that precedes formal cholestasis. The evening intensification reflects the circadian pattern of bile acid metabolism. Hepatic bile acid synthesis peaks in the afternoon and evening, meaning the circulating bile acid burden and the associated itch stimulus is highest in the hours before sleep, an itching that becomes inexplicably worse after dinner and persists into the night. In the absence of any skin condition, is worth connecting to hepatic bile handling rather than simply treating symptomatically. Unexplained itching that worsens in the evening and resists antihistamines is the liver's bile salt metabolism, expressing itself through the skin. It is a signal, not a skin condition. Signal 3. Discomfort or fullness in the right upper abdomen. The third signal is a dull, non-specific sense of fullness, pressure, or mild discomfort in the right upper quadrant of the abdomen, the region beneath the right rib cage where the liver sits. This is distinct from sharp pain, from the colicky pain of gallstones, and from epigastric discomfort associated with reflux. It is a vague heaviness or awareness of that region that most people attribute to trapped wind, posture, or a dietary intolerance. The liver itself contains no pain receptors in its parenchyma. The organ tissue cannot generate pain signals directly. What it has is a capsule, Glisson's capsule, a fibrous covering that is richly innervated with stretch receptors. When the liver enlarges, as it does in fatty liver disease and hepatic inflammation, the capsule is stretched by the expanding organ within it. The stretch receptors generate the dull pressure-type discomfort that patients describe as an awareness of that region rather than a definable pain. It is not severe enough to be alarming. It is persistent enough to be noticeable, particularly after meals, when portal blood flow to the liver increases and an already engorged organ expands slightly further. The liver cannot feel pain from within, but it can signal through its capsule when it is swelling. A persistent right-sided heaviness after meals is Glisson's capsule communicating what the liver cannot say directly. Signal 4. Elevated triglycerides and low HDL on a routine blood test. The fourth signal is one we have discussed at length in the biological age video, but its relevance as a liver stress indicator deserves specific emphasis here. An elevated fasting triglyceride level and suppressed HDL cholesterol, particularly in combination, is one of the earliest blood test detectable signs of hepatic fat accumulation and impaired hepatic lipid metabolism. The liver is the primary site of triglyceride synthesis and HDL production. When hepatocytes are fat infiltrated and insulin resistant, several things happen simultaneously to the lipid profile. The liver produces excess VLDL particles loaded with triglycerides, driving fasting triglycerides upward. HDL metabolism is disrupted, with increased HDL catabolism and reduced ApoAI synthesis, driving HDL cholesterol down and the atherogenic lipoprotein profile associated with NAFLD, elevated triglycerides, low HDL, and a predominance of small dense LDL particles emerges as a direct reflection of hepatic lipid dysfunction rather than simply dietary fat intake. Research published in Hepatology has demonstrated that the triglyceride to HDL ratio correlates directly with the degree of hepatic steatosis on imaging, meaning the biological age marker discussed in the previous video is also simultaneously a liver health marker. The same ratio, the same upstream driver, expressed in the same number. The triglyceride to HDL ratio is not just a biological age signal, it is a liver signal. When the ratio is elevated, the liver's lipid processing capacity is telling you something, even when the ALT and AST on the same panel remain in range. Signal 5, worsening insulin resistance despite dietary effort. The fifth signal is one of the most clinically instructive and one of the most demoralizing for the people experiencing it. The person who reduces their caloric intake, reduces their sugar consumption, makes genuine dietary changes, and still finds that their fasting glucose, their post-meal energy crashes, and their abdominal circumference are not improving as expected. The dietary effort is real, the metabolic response is blunted, and the reason in many of these cases is that the hepatic insulin resistance driven by fatty liver is sustaining a degree of systemic insulin resistance that dietary change alone, without addressing the liver fat specifically, cannot adequately reverse. The liver is the primary site of insulin-mediated glucose suppression. After a meal, the majority of the insulin released by the pancreas acts first on the liver to suppress hepatic glucose production, a process called hepatic glucose output, and to promote glycogen synthesis. When the liver is fat infiltrated and insulin resistant, this suppression is impaired. The liver continues producing and releasing glucose even in the presence of adequate insulin, driving the fasting hyperglycemia and compensatory hyperinsulinemia that define the early metabolic disease cascade. Dietary changes that reduce insulin demand at the cellular level will have a limited effect on systemic insulin resistance. As long as the liver remains the primary site of insulin resistance, unchecked glucose output, the liver must be specifically targeted through the interventions discussed in the solution section for the metabolic response to dietary change to become fully effective. If the diet has improved, but the metabolic markers have not, the liver may be the missing piece. Hepatic insulin resistance can sustain systemic metabolic dysfunction independently of what is being eaten, and it requires targeted intervention, not more willpower. Signal 6, skin changes, spider angiomata, palmar erythema, or unexplained acne. The sixth signal involves the skin, but in a different way from the inflammatory skin conditions driven by chronic stress described in the stress video. The liver processes and deactivates circulating estrogen. When hepatic function is impaired, estrogen clearance is reduced, producing a state of relative estrogen excess in both men and women that expresses itself in several specific and recognizable skin findings. Spider angiomata are small vascular lesions, a central red spot with radiating vessels that blanch under pressure and refill from the center, that appear most commonly on the upper chest, shoulders, and face. They are caused by estrogen-driven cutaneous vasodilation. In the context of significant liver disease, multiple spider angiomata are a recognized clinical sign. In the context of early hepatic stress, 1 or 2 new spider angiomata appearing in a middle-aged adult without a prior history of them is a subtler indicator of impaired hepatic estrogen clearance. Palmar erythema, a redness of the palms, particularly at the thenar and hypothenar eminences, carries the same mechanism and the same significance. And the unexplained acne or sebaceous skin changes that some people develop in midlife, without prior acne history, can reflect the effect of relative estrogen excess on sebaceous gland activity through the same impaired hepatic hormone clearance pathway. These are not alarming findings in isolation. In the context of other signals on this list, they are relevant data points. The skin is a canvas for the liver's hormonal output. When the liver stops clearing estrogen efficiently, the skin shows it in vascular patterns, palm coloring, and sebaceous activity that most dermatologists treat without ever considering the upstream hepatic driver. Signal 7, difficulty tolerating alcohol. That was previously well tolerated. The 7th signal is one that people notice acutely but rarely connect to liver health, a progressive reduction in alcohol tolerance that is not explained by age alone. The person who could comfortably manage 2 glasses of wine in the evening now finds that a single glass produces a disproportionate hangover, unusual fatigue the following day, or a degree of cognitive fogginess that seems out of proportion to the quantity consumed. Alcohol is metabolized almost entirely in the liver through a 2-stage enzymatic process. Alcohol dehydrogenase converts ethanol to acetaldehyde, a toxic intermediate, and aldehyde dehydrogenase converts acetaldehyde to acetate, which is non-toxic and can be further metabolized. Both stages require adequate hepatocyte function and NAD+ availability. When hepatocytes are fat infiltrated and their mitochondrial function is compromised, both the rate of alcohol metabolism and the capacity to buffer the toxic acetaldehyde intermediate are reduced. The result is a greater and more prolonged exposure to acetaldehyde per standard drink, producing worse nausea, worse headache, greater cognitive impairment, and greater next-day fatigue than the same quantity would have produced from a healthier liver. This reduced tolerance is not simply a sign of aging. It is a sign that the liver's processing capacity has diminished, and because alcohol is itself a hepatotoxin that accelerates fat accumulation and inflammation in an already stressed liver, the practical implication is that continuing to drink at previous levels in the presence of this signal is actively accelerating the hepatic damage that produced the intolerance in the first place. A liver that cannot handle what it once handled is not simply aging. It is signaling that its processing capacity has been compromised, and continuing to demand what it can no longer deliver compounds the damage with each exposure. The 7 signals described above go unrecognized as liver indicators, not because people are inattentive to their health, but because the conventional framework for evaluating them, fatigue investigated through iron levels and thyroid function, itching treated with antihistamines, abdominal discomfort attributed to IBS, skin changes managed by a dermatologist, does not include hepatic function in the differential unless a blood test has already returned an abnormal liver enzyme. That threshold is set at a point where the liver has already been under strain for years. The signals that precede it have simply never been given a framework that connects them to their origin. That framework is what this video provides. So what is the practical response if you recognize 3 or more of these signals in yourself? I want to frame this carefully. The liver has a regenerative capacity that is unmatched by any other solid organ in the body. Early stage NAFLD, hepatic steatosis without significant inflammation or fibrosis, is fully reversible with the right interventions. Even moderate fibrosis can be meaningfully reversed when the upstream drivers are addressed. What the liver cannot do is regenerate from cirrhosis, the end-stage scarring that replaces functional tissue permanently. The window for meaningful reversal is real and wide, but it is not unlimited. Acting on these signals while the liver still has its regenerative capacity is the entire point of this video. The third intervention is coffee, which, despite its complicated reputation in popular health culture, has one of the most robust evidence bases of any dietary component for hepatoprotection. Research published in the British Medical Journal and the Journal of Hepatology, drawing on multiple large population studies, has consistently demonstrated that habitual coffee consumption, 2 to 4 cups per day, is associated with significantly lower rates of NAFLD progression, lower ALT and AST levels, and a substantially reduced risk of hepatic fibrosis and cirrhosis. The active compounds responsible include chlorogenic acids and other polyphenols that reduce hepatic oxidative stress and inflammation, and carvedil and cafestol, dinerterpenes, with direct antifibrotic properties. This is filter coffee or espresso, not instant coffee at reduced potency, and the protective effect is present for both caffeinated and decaffeinated varieties, suggesting the benefit is driven by the polyphenol content rather than caffeine specifically. The fourth intervention is alcohol reduction or cessation for anyone who recognizes the reduced tolerance signal described above. The liver's capacity to regenerate depends on reducing the ongoing hepatotoxic insult, and continuing to consume alcohol at a level that is producing disproportionate symptoms is compounding damage to tissue that is already working below its designed capacity. This is not a permanent prescription for abstinence for everyone, but in the context of the signals described in this video, and particularly in the context of signal 7, it is a clinical priority that deserves honest reassessment. Finally, and I want to be clear on this, if you are recognizing multiple signals from this list, a blood test that includes liver enzymes, ALT, AST, GGT, bilirubin, albumin, and a fasting lipid panel, including triglycerides and HDL, is entirely appropriate to request from your GP. A liver ultrasound, which is non-invasive and widely available, can directly visualize hepatic steatosis and provide a baseline from which to measure improvement. Neither of these investigations is excessive or anxious in the context of a pattern of signals pointing toward hepatic stress. They are the appropriate clinical response to information your body has been providing for longer than the blood tests have confirmed. Let me bring this back to what I see clinically, because the significance of these signals becomes considerably more concrete when it is grounded in actual patient trajectories. In emergency medicine, advanced liver disease presents in ways that are both clinically severe and, in retrospect, entirely predictable from the preceding years of unrecognized signals. The ascites, fluid accumulation in the abdomen, in a patient whose right-sided discomfort was attributed to IBS for half a decade. The variceal bleed in a patient whose fatigue, itching, and elevated triglycerides had never been connected to a hepatic picture. The hepatic encephalopathy, the confusion and cognitive deterioration produced by the liver's failure to clear ammonia, in a patient who had been told their cognitive slowing was stress or menopause, or simply getting older. These are not presentations that could not have been anticipated. They are presentations that could have been anticipated had the earlier signals been connected to their origin and acted upon. I have also seen the other side, patients who, after recognizing the pattern and addressing the upstream drivers, return with normal liver ultrasounds 12 months after images that showed significant steatosis. Patients whose ALT has normalized, patients whose triglyceride to HDL ratio has improved dramatically, whose fatigue has lifted, whose right-sided discomfort has resolved. The liver's capacity to recover when the insult is removed is, clinically, one of the most striking and most hopeful things I see in follow-up. The regeneration is real, it is measurable, and it is available to almost everyone whose disease has not yet progressed to fibrosis. NAFLD is the fastest growing cause of liver transplantation in the developed world and is projected to become the leading indication within the next decade. It is also, in the overwhelming majority of cases, a metabolic disease, the hepatic expression of the same insulin resistance, visceral fat accumulation, fructose excess, and sedentary behavior described across this series. The liver is not a separate organ developing a separate condition. It is the most metabolically central organ in the body, and when the metabolic environment deteriorates, it deteriorates first quietly, without pain, and with only the 7 indirect signals described in this video to announce what is happening. What connects this video to every other video in this series is the same upstream story. The insulin resistance driving visceral fat drives the portal free fatty acid delivery that infiltrates the liver with fat. The fructose in the fruit juice and the sweetened yogurt that were supposed to be healthy choices floods the liver with the substrate for hepatic lipogenesis. The chronic sleep deprivation and the stress cortisol compound the hepatic insulin resistance. The declining triglyceride to HDL ratio announces the impaired hepatic lipid metabolism. The afternoon energy crash reflects in part the impaired hepatic glucose management. The biological age the ratio estimates is, in significant part, the biological age of a liver that has been quietly carrying a metabolic burden. It was never designed to sustain at this level for this long. Addressing liver health is not a separate intervention from addressing metabolic health. It is the same intervention, the same dietary restructuring, the same exercise, the same sleep quality, the same stress management that improve insulin sensitivity, reduce visceral fat, lower the triglyceride to HDL ratio, slow biological aging, and reduce the risk of cardiovascular disease, dementia, and kidney disease. All of those simultaneously reduce the hepatic fat content, the hepatic inflammation, and the progressive fibrosis risk that, unaddressed, leads to the presentations I described from the emergency department. So let me bring this full circle. The liver sends signals before it fails. They are not dramatic, they are not unmistakable, they are a persistent fatigue that sleep does not resolve, an itching that worsens in the evenings, a right-sided heaviness after meals, an elevated triglyceride to HDL ratio on a routine lipid panel, a metabolic resistance to dietary effort, skin changes driven by impaired estrogen clearance, and an alcohol tolerance that has quietly diminished. Separately, each of these is easy to explain away. Together, they are a pattern, and a pattern that appears years before the liver enzymes cross any threshold, and years before any diagnosis is made. The liver is the most forgiving organ in the body. In one sense, it can regenerate from damage that would be permanent in almost any other tissue. But that forgiveness is conditional on recognizing the signals early enough to remove the insult that is producing them. Fructose reduction, aerobic exercise, coffee, alcohol reassessment, sleep and stress management, blood tests and an ultrasound if the pattern is present. These are not difficult interventions, they are targeted, accessible, and for a liver that has not yet fibrosed, overwhelmingly effective. The liver will not ask for help until it is in serious trouble. These 7 signals are the closest it comes to asking early. Now you know how to listen. If this video gave you something genuinely useful today, a pattern you recognize, a connection you hadn't made, or a conversation you now know to initiate with your doctor, please subscribe to the channel and help us reach more people like you who deserve this information.